Was very kind. So yeah, everyone, my name is Mike Isaac. I think that introduction was wonderful and lovely. So thank you so much. Just a little background on myself. I've been at the university for um, a really long time, since 2000 and I'm going to say uh, 2007, I've been here. I started in tech management at OTM. I ended up moving to what was then called the Office of Research Services, ORS, which is now OSP. And in 2017, I came to the Cancer Center after swearing to myself that I'd never get involved with clinical trial management because it was really just so complicated. Disclaimers, I've got nothing to disclaim. I did want to let you know that the majority of my portfolio is industry sponsored. Um, and and that applies just fine to investigator-initiated trials. Um, my focus will be less on federal grants. However, everything that I'm doing applies itself just as equally to federal grants. It's just sometimes in a different order. And if you want, we can talk about that later, how the kind of order of operation changes a little bit. Speaking of which, though, somehow you're going to be notified that a study is happening. Maybe you are the one doing the notifying that the study is happening, and you're in charge of the budget as well. For me, usually we have a team that helps select studies. They come to me and to my team, and our job, the kind of the overview is we're going to assemble and review our essential documents. We're going to then use that to draft a coverage analysis. And from that coverage analysis, we're going to figure out our budgetary needs. And from that point on is really when things get moving. I've kind of grouped these last two together, negotiate the budget and get internal approvals ready for the study. That's going to be happening in tandem. For our cancer center, kind of timing matters for us, and we kind of have a stopwatch that starts as soon as we
Also
get our
walking
submissions going. No,
in
thanks.
7.
Um, and so basically you want to get as much as you can done at the forefront for my team, for our sake. We have a lot that we can do initially, and then once that negotiation of the budget starts happening, that's when all the balls start rolling. And as long as we've prepared ourselves at the forefront, we're in a good place. So I talked about essential documents. What that essentially means is a study protocol, which if you're doing an IIT, that study protocol is probably a draft right now. And so just make sure your conversations and your communication with whoever is holding the keys to that protocol is very good and clear, because as that protocol kind of evolves and changes, so too does your budget. For an industry sponsor, though, we'll have a sponsored budget template. If you're doing an IIT, sometimes your sponsor has a budget template that they want you to put things to, and that is very helpful. Use that. If they don't, then you're free to use your own, make your own, or just reuse, a template that you've used before that you're comfortable with. The other essential documents are the informed consent form, the clinical trial agreement, and then there's really just a long list of other kind of ancillary documents that may or may not apply to your study. That's study specific, site specific. So what you need to have in your portfolio, what you should have in your own toolbox that you're making, is a standard fee schedule. And I'll go into detail about that, but a standard fee schedule is what we use to charge our startup fee and our maintenance fee. And it includes kind of the IRB fees. It's kind of a 1-page or 3-page packet that we send to our sponsors to say, hey, before we even begin this relationship, here are our costs, here are our needs, and we present them for you to accept. They're not something that I negotiate. We don't have a different startup fee for AbbVie than we do Pfizer. That is something that we do clear and consistent across the board. I put a date on that document to let sponsors know that this is what's been being passed around for the past year and a half or so. Other site documents is going to be what we use a lot as our clinical charge master. So that's something that the hospital provides. It does need to be kept confidential, obviously. And then any other internal templates that may apply that you may need. With those essential documents, we get these essential questions. And since this entire presentation is really focused on budget. We're going to focus our questions on that. So looking at all the documents that we have, we want to know what charges are going to happen. And there's really kind of two different buckets of charges. There's administrative charges and there's procedural charges. So there's a charge of your office and operations getting this site running and maintaining it. And that kind of goes back to those standard operating fees that I talked about, our startup fee and our maintenance fees. But the other piece of that, and the much more complex and complicated part, is the procedural fees. Of those procedural fees, the questions that you're asking yourself are, or maybe not you, but you're asking all of your resources. So that would be the PI and the research coordinators and everyone else involved. But we want to figure out what should be charged to the patient insurance. We need to find out what must be paid by the research sponsor. And then we also have to discern what else is the research sponsor intending to pay for. We kind of have these obligations as we're getting into this when we're looking at a budget. And if a sponsor is intending to pay for something, then we have to accept it. And that is a duty to our patients. It is a duty to the institution to stay in compliance. But so you have to kind of review everything with a fine-tooth comb to answer these questions. So these are the questions we're constantly asking ourselves throughout the rest of this presentation and throughout the entire budgeting process. So looking at those documents, there's a study protocol, and from that, we're going to glean what charges will occur from carrying out the study. We're going to find out what procedures are happening, right? We're going to be looking at the schedule of events, and we're going to be looking at wherever we can to dial down the detail. This is really your main reference point. So get nice and familiar with it. Then there's a sponsored budget template, which is often an eyesore to look at. They often kind of stretch out. I say to the like you need like 6 screens in a row just to see it all. It's a hard thing to look at. I recommend getting yourself well acquainted with your viewing options in Microsoft Excel. But from that, from that template, as we're asking our questions, we're figuring out what is the sponsor indicating it will pay for. Again, a sponsor coming out and saying, I'm going to pay for this, means right away that the sponsor is paying for it. We can't go back and say, no, we'd prefer to charge that to our patient insurance. If the sponsor is paying for something, especially if this is a multi-site trial and the sponsor is wanting to pay for a physical exam for everyone, then you can't be the institution that says, no, we're going to charge it to our patients. That's actually a Medicare no-no. That is a billing compliance no-no. But from the budget template, there's kind of 2 different methods that you're going to be able to invoice and the sponsor is going to be able to pay you. And that's via milestone payments and invoiceable items. And I just want to kind of dial into that just for a second, because it can sometimes get confusing for some people. Milestones. Milestones are going to cover a range of items at significant points during the study. And generally, that's going to go by your protocol calendar. So at a screening visit, these are the items that are going to hit for all of your patients. They're going to these are the items that are going to, sorry, first, here are the items that your patient's going to encounter. From that, you're going to have a list of, these are the items that the sponsor's paying for. And from that, you see that it all totals up to $6,387. And so at the end of the day, a screening visit occurs. You let the sponsor know that a screening visit occurred. The sponsor pays you that milestone payment. It's a very easy way to make things happen. Those often don't even require an invoice for industry sponsors. They're just something that when they get into their own, the study records is entered in a patient visit, they know that we need to pay you this chunk of money. So really, again, administrative burden is really low. Invoiceable items are the opposite of that. So that is an itemized list of things that are happening. And generally speaking, you have a mix of milestones and invoiceables. So whereas the milestones covering everything that's going to happen for a patient, the invoiceables are things that are going to be more patient specific. It's going to be depending on the situation. So we're not going to run a pregnancy test on all of our patients because it's only for women of childbearing potential. Not every patient's going to have a optional biopsy. But those that are, the sponsor's not going to want to pay blanket across the line for everyone to get a biopsy. And on our end, we can't afford to, you know, to eat the cost of one because we haven't budgeted for it otherwise. So it's more difficult to track. You need a good system for tracking them. And I believe, and this is probably another presentation for another day, that Encore is the clinical trial management system we use to for everything, but especially on the financial end, we're able to track our invoiceables through that. And if that becomes a tool resource for you, I would highly recommend it. For grants and IITs, we do generally combine all these to get an overall patient cost. So with when you're doing a grant, you're not going to be invoicing, say, NIH for individual items. You're going to be kind of getting a general idea of how many patients are going to need a service and what services they're going to need, and it's going to be a big old calculation. So, okay, so my PI says that everyone's going to get a physical exam, but only 40% of the patients are going to be getting a pregnancy test. Then you kind of figure that out and you budget. Grant budgets usually have a little bit more flexibility than an industry budget. Industry budget is pretty much line by line. You have to be exact. Let's keep moving on. So that was on the budget. The next of the three main essential documents was the informed consent form. That's our agreement with patients is binding. It is something that your research coordinators are going to be sitting down with the patient, going through every single page. Sometimes these things are a nice quick 10-page read, and sometimes they're like 35 pages. There's a lot of information in there. And there's information about that really truly does affect the budget. And those three big pieces are what are the costs to the patient? And so that is to say, what is their insurance going to be billed? A lot of times there's confusion over what it means for a patient to have a cost. If insurance is picking something up, that is a cost to the patient, because number one, we don't know that the patient's insured, but number two, if the patient is insured, there's co-pays and deductibles and things that have to go on. So you can't tell a patient that they're not going to have any cost because everything's going to insurance. The next bit is going to be, will the patient be paid? And there's really two buckets for payment. There's compensation, and then there's reimbursement. Both of those are governed differently. Compensation has got all sorts of IRS regulations that we have to go by, and reimbursement, obviously, like if you ever do anything for UIC and you get reimbursed for it, that reimbursement is when you submit a receipt and then you get reimbursed for that money. And that's the same thing for patients. If we are reimbursing patient for travel, then the patient is presenting us with their travel fees and we are reimbursing that. If we are compensating patients so that they can spend that money on travel, then we're handing them, like, say, $20 to cover gas or bus fare or something like that. So those are two different pieces. One is new money being given to the patient, and the other is the reimbursement of money spent by the patient. The third thing is just a general idea of what the procedures the patient will encounter. That, I think, is the most important thing, or one of the most important things that the patient is getting from the consent form, is getting an idea of what is going to happen should they participate in the trial. And then from those procedures, what we're trying to glean is whether they're medically necessary or done strictly for research purpose. And we'll get into a little bit of that as we talk about the coverage analysis. But the coverage analysis, my, again, disclaimer is that is a full 1-hour presentation in and of itself. So just a quick review of synopsis of what we talked about. There's the protocol, the budget, the informed consent. Protocol is what the site's doing. Budget is what site's paid for. And the informed consent is, again, indicating all these things to the patient. And our job is to make sure the budget is accounting for everything that's happening in the protocol. And then we need to make sure that the budget is consistent with what the cost section of the consent form says. Now, the protocol and the consent form are both going through IRB review and approval. There's a chance that they may change depending on sponsor type and depending on IRB type. The budget that we have is negotiable. That's the most malleable document that we have. So right up front, we need to make sure that we are kind of sculpting that budget to fit both the consent form and the protocol. Okay, other important documents are the clinical trial agreement. That is the legally binding document between the university and the funder. I want to make it clear it's between the university and the funder. Our PI will sign off as an acknowledgement, but it's really who is held responsible and liable for whatever's in that contract is the university, and that is why we can't go off signing these things on our own. They have to be routed through the Office of Sponsored Projects, OSP, which is part of the Office of the Vice Chancellor for Research. So the things that we are kind of reviewing that CTA for now, that the clinical trial agreement gets submitted to the Office of Sponsored Projects, and it's going to be reviewed by a very capable negotiator. And they're going to be looking out for the university's interests. So that in mind, you get to then instead worry about your own interests. And so you want to make sure that that CTA is meeting your needs as well. And these are pieces that aren't necessarily going to get touched by whoever's negotiating your study at OSP unless you actually ask them to do so. So one of those things that the most important thing on most of my clinical drug trials is what investigational agents are provided by the sponsor. So usually the main investigational agent is provided by the sponsors. It's their own drug. And I'm going to slip in one more disclaimer. I interchange the words sponsor and funder too much. They are different things. And that's probably a different that's probably a different presentation as well. For me, I come from sponsored projects. That's my background. And so I constantly call the funder the sponsor. Oftentimes the funder is the sponsor for a industry sponsored trial, but for a grant funded trial where your PI has written the protocol, USC is the sponsor and whoever the grant funding agency is the funder. So I apologize. It's going to happen more than once that I'm going to call a sponsor a funder and a funder a sponsor because in my head they're the same, but they're really not. The sponsor is who is the one in charge of that protocol. The funder is the one who is actually providing the funds. The next question is any specialized equipment provided. Sometimes I'll see things like an ECG machine will be provided or various tablets or things like that. And usually there's a provision in the contract that says we'll be providing that. And then at the end of the trial, you can either keep it or we're going to require you to send it back to us, or it needs to be destroyed. But those will all be in the CTA, and you're just going to want to make sure you know what's going on, because if equipment starts arriving at your office, you need to know what you're accountable for. Also within that CTA are the invoicing requirements. Those are negotiable. So they could say, we need to be invoiced for anything that happens within 15 days. And that would be crazy to me. I have a wonderful post-award person who takes care of our invoicing, and we do it on a quarterly cycle. So in all of our CTAs, I make sure that the invoicing requirement is no more frequent than every 90 days. The withholding percentage is something that I've actually seen starting to get teased out, which is wonderful. But for the most part, a withholding is the sponsor saying, okay, we're going to pay you $10,000 for screening, but we are going to actually withhold 15% of it. So we'll pay you $8,500. And then when the trial's all done and we have all your data, they hold that kind of as collateral to say that they'll give you this percent, the missing piece at the end. And that kind of stinks, because that means depending on what that percentage is, your budget may be going into the red midway through your trial. That withholding percentage is negotiable. I can usually get it down to, if a company starts at 10, you can get it down to 5. And if it starts at 15, you can usually get it down to 5. And the idea is that the rationale behind that is like you have to make ends meet, right? It doesn't look good to see things in deficit. Screen failures is another thing that is negotiable. So screen failures, if a patient comes in for a screening visit and doesn't meet the criteria for one reason or another and does not end up enrolling onto the study or onto treatment, sorry. That screen failure, usually the contract will govern, will say, okay, you get X amount of screen failures. Obviously the company wants, the funder wants to protect itself from you just like screening everybody off the street and making a ton of money. Whereas you want to protect yourself from, honestly bringing in patients that meet the criteria for screening and then for one reason or another don't make it through. But that screen failure limitation can hurt you. So if it says something like there's, up to 10 screen failures, great. Just make sure that you talk to the study team, talk to your coordinators, talk to your PI, make sure that that is a reasonable number. If it says there's up to 2 screen failures and, you're talking with the study team, they're like, yeah, this is going to be a hard one to find. The enrollment criteria is really tough to find patients that meet exactly these criteria. Then you may need to know, you may need to either boost up that, screen failure limitations, or you need to like rethink the feasibility of the study. Other big piece is the reporting requirements. And this
I have a
doesn't,
question.
oh, please.
Does everyone like score them individually and then you meet, or like the group meets and then you score them as the group?
Usually, so we kind of have a 2-step process. So all these studies first go to a disease team.
Yeah. Okay.
So all the studies go to a disease team, which is a really power meeting of the minds for us physicians who are all working with this type of patients. They're going to go through and they're going to look at it. They're going to say, okay, just looking at the criteria, we see X amount of these patients in clinic a year. So that is the first round, and that is everyone meeting together and discussing. Our second round is a feasibility meeting among just our clinical trials office, and we take pieces from every kind of bit of our unit. So we've got our, and everyone's looking at it beforehand, and then we meet and we discuss our findings, what we have. So it's usually our clinical research coordinators who go in and say, okay, so from disease team, they said we would have about 30 patients present this way per year. But now looking at the screening requirements, we're dialing it down and we're saying, okay, but we need patients who fall into this category from those 35 patients. How many are going to fall into this category of where they are in prior treatment and current treatment and how long it's been since this last thing? And that, I think, is where those pieces come out. So I hope that answers your question. We usually don't ask each other cold. We usually have, the finance person is not the only one reviewing these documents, the CTA aside, but like the protocol and the manuals and the consent forms. We have a team of individuals looking at that. And that's where we determine those kind of numbers. Going back to reporting, so that would be like how quickly you need to get data entered into the sponsored system. For that, you need to be in contact with whoever is going to be responsible for putting that data in. We have kind of a general list of like no more than X amount of days for this and X amount of days for that. And generally speaking, whatever the sponsor puts in their contract, we have really good luck. I wouldn't say if it's even luck. We have a good track record of getting the timelines that we need because we back it up with rationale. We need at least 4 days for this because someone has to be consulted or something like that. But what I mean to say is all these things are negotiable, and so your chance to negotiate them is now. It isn't after the study started up and you realize that, oh, we've got we've got a ton of screen failures, or with this withholding, we can't make ends meet at all, or my data person cannot keep up with the reporting requirements. You need to comb through and find out what is relevant to you. And these are really the big pieces that I'm picking out. And they're going to be pretty consistent across all contracts being there. But those are the pieces you should look at. There are much bigger fish to fry in that contract, but luckily you have the fine folks at the Office of Office of Sponsored Projects Programs. OSP will take care of it for you. The other document, and I think this is one of the last two ones that I'm going to talk about, is the lab manual. From time to time, this has been helpful for me, where we've got a litany of different labs that are going to be required for something. And the lab manual is telling us, actually half of those are going to be sent to a central lab. Sometimes, especially for a multi-site giant study, samples, specimen are sent to a central location, and they're all like run so that it's all calibrated the same and they're getting the same, it keeps their metrics, I think, consistent. The other thing it will help you do is if you're like shipping some sort of specimen, to know exactly what type of specimen is going to be needed. We rely on pathology to prep all of our tumor slides. And so we need to know what type of tumor slides are going to be needed so we can help price that out. But that is something that you get from the lab manual. And then the other bit is a pharmacy manual. Helps us know which agents are investigational, what components are going to be supplied by the sponsor, and if there's any kind of special storage or dispensing need for the investigational agents. We are starting to come into much more complicated studies where it is
Why can't you?
requirements of holding and receiving and storing and dispensing the investigational agents are getting more and more complex. And so those teams need to be in the know of what they're going to be required to do for you, and then that may incur extra charges. Okay, so this coverage analysis is, like I said, it could be probably a 2-hour presentation on the coverage analysis, but the main idea of the coverage analysis is to have your big giant schedule of events from the protocol. And then going through the protocol, making sure that schedule of events is complete. And then you're listing everything out at all the time points that is happening. And then you're giving it a designation saying, okay, this is something that needs to be sponsor paid, something may be billed to insurance, something that is going to be handled by a central lab, or something that is just administrative in general. To create that draft coverage analysis, what my team usually does is we go into our protocol schedule of events, we grab that grid, that calendar, we export it to a PDF, or don't export it to a PDF. Export the PDF into an Excel. How many times have I done that where I've gone and I've exported something into the wrong, I hooked it to PowerPoint for some reason, I don't know why. But turn it into a spreadsheet. You want it to be a Microsoft Excel workbook so that you can take it and then you put it right into this really handy template that the Clinical Research Finance Office, which is part of UI Health, provides for us. And I put the link here for their where you can get their template and get some information from them. But so you turn that into a Excel document, and then you copy the list of procedures into the list of procedures. You kind of set up the headings, right? So you've got the cycles and the days and everything that's going on there. We work with cycles and days in oncology. And then you populate where things and when things are happening. You're going to need to fill in your draft coverage analysis. I call it a draft coverage analysis because you're not the deciding factor of the coverage analysis. That coverage analysis is going to have its own review with the Clinical Research Finance Office. But you're going to have to draft it. And what you're going to be doing, and for some reason I didn't put it in this slide, the absolute most important resource and reference when you're doing a coverage analysis is people. So you're going to want to talk to your PI. We have I don't do anything without consulting our associate director, who's the head of our clinical team, and she is just a deep well of knowledge in terms of helping determine what we see normally in clinic, and it helps determine how things get billed. But from the sponsor budget, anything that you see in a sponsor budget, so you're looking at that big, long, like that long Excel sheet that the sponsor sent you, anything that the sponsor is paying for, we're marking that as S if it's a billable item. Now, a billable item means something that if you were to go to see a doctor, you could expect a bill for that. So, for example, like if you go for a physical exam, you would expect a bill for a physical exam. If you go and you get, let's say, some lab work done, you're going to get billed for the lab work. If you go in and the doctor says, how have you been feeling the past couple of days? And you say, oh, you know what, I actually I've had a headache for the past 2 days. You don't get a bill for the doctor asking you if you had a headache. You do get that bill for the exam that you came in for. But those questions, those are non-billable items. That's in that case, I would call that adverse event reporting or something. I don't know. But there are plenty of items in that budget that are not something that is going to result in an actual charge from the hospital. Those things that are still being done to represent time and commitment from your staff or the PI are going to be marked as an E for effort. From the protocol manuals, you're going to be sure to delineate what is marked as central lab. If a study is taking blood and sending it centrally to do complete blood count, then I want to make sure that's marked as central lab. Otherwise, when we have a patient on trial and they come in and perhaps, in addition to the lab work that's been sent out, for another reason, a complete blood count has been done locally, I want to make sure that we can say that that is not a study related lab, because we know that anything done for the study in this case was sent to a central lab, not to our hospital for processing. From the ICF, if the ICF says the patient is not responsible for XYZ, then we need to make sure that in our coverage analysis, it says XYZ. Now, bear in mind, at this point, we should have already made sure we had a match between the budget and the ICF. I think that there are sometimes some confusion when looking at a budget and looking at an ICF and then starting to put that into a coverage analysis. You have to make sure that you are looking at the whole picture at once, making sure that what you see in one document is lining up with the other document. Otherwise, it's confusion, honestly, and you need to figure out what the intentions of the sponsor is. If the sponsor generated both these documents and they seem to not be saying the same thing, then we need to figure out, okay, what does the sponsor mean here? Which of these has to change? So that is your responsibility to figure that out. Then similarly, any item that the patient or patient's insurance will be responsible for should be marked for N. So here are the designations over on the side here. S is sponsor paid, N is normal care, CL is central lab, and E is for effort. These are the designations that our clinical research finance office uses. Let's keep moving on. Okay, so quick word of warning as you're making this billing grid that is going to turn into your cost analysis as well. Beware of missing pieces. And that would be where you're kind of getting an incomplete picture from the budget. So here I have just some examples that I've run into probably in the past 2 weeks. But here we have on the schedule, it says EKG, but the protocol calls for an EKG or an echo. So, okay, well, I want to make sure that I put something in about an echo now into this list because they're different costs. And if it's either one or the other, I don't want to do an echocardiogram and charge the sponsor for an electrocardiogram. I've got, let's see. Ooh, I don't have a line there. If you see that comprehensive metabolic profile, check the either lab manual, honestly, the protocol will tell you what they mean. Because different centers run a CMP differently, or sometimes they just call them, sometimes they call them clinical chemistry. And then they have just a list of like 32 different labs that are happening, and they want to charge for a comprehensive metabolic panel. And the reality is it's really 3 times as expensive. So you need to make sure that whatever labs are listing is exactly how you're going to get billed for those labs. Or here you've got uh, thyroid function tests at the same time as fasting labs. These are just examples. So now you've got disease assessment. Sometimes it's just a disease assessment. And you have to figure out what they want. Sometimes they'll say chest, abdomen, pelvis. We do a lot of CT, chest, abdomen, pelvis. The sponsors always want to bill it as one thing. It's just a CT of chest, abdomen, pelvis, and UH doesn't do that. We do a chest and we do an abdomen, pelvis. So there are 2 different things. You got to keep them separate. Also in oncology, we do all sorts of special interpretations of these scans. So aside from the professional fee for the read of the actual CT scan, we do additional kind of specialized reads that have a bunch of different names. But those are all separate costs, and those aren't always included in the budget. So we need to make sure we throw them in there and make sure that we're getting compensated, because we will get charged for them. Then down here, we have hidden fees as well. So I've got missing pieces, so things that are kind of missing from the list. And then the hidden ones that are kind of like assumed, but not necessarily there, not necessarily spelled out in black and white. So we've got the treatment of investigational agent A. Okay, well, investigational agent A is going to require a dispensing from our pharmacy. And then it's going to need to be administered. So if it's an IV, that's one charge. If it's sub-Q, it's another charge. If it's an oral tablet, it's no charge. And then there's the agent itself. So are we being provided that agent? Are we going to have to source it ourselves and then get reimbursement for it? And then other things like, especially when it comes to samples, there's the blood draw and the tumor tissue, but then there's also like the prep of those things, and then the shipping of those things. So make sure you're capturing all of your costs that way. A slower word of warning. So again, everything has to go by the PI. The PI is the one who's ultimately responsible, not responsible, but it's their word. So you want to make sure that this is an accurate depiction of what their intentions are. So ask the PI to verify at all times anything you can identify by the document sent alone. All the procedures that have been deemed as standard of care, make sure that's right. The frequency of repeated procedures. So like, yeah, we usually get a physical exam for this patient, but do we get them every week? Maybe. Okay, we usually get CT exams or CT scans for this patient, but do we get them every 6 weeks, or is it every 12? So that kind of thing makes a huge difference for your coverage analysis and eventually your budget. I've already talked about the coverage analysis is draft until it's reviewed and approved by the CRFO, and there's some information there about the coverage analysis. Okay, so we are 40 minutes in, and I'm just starting the working budget. So again, there's so much prep work that goes into getting a budget together, and so much of it happens at the beginning. You get kind of your stage set. Once we have our working budget set, then it's just kind of a conversation. So this last part is our working budget, and this is probably the most time-consuming part of the whole brigade. The working budget. Okay, so you've got that. You've got the working budget. For me, I like to have a working budget that is separate from the budget I'm sending to the sponsor back and forth, because I'm putting in our full fees into our working budget, and then I'm starting to work with percentages of that fee. So when you're doing a research study, you apply a research rate to it from the charge master. And that rate is going to be dependent on the sponsor type, whether it is federal, whether it is industry, whether it is foundational. Those all get a different rate. And in addition to that, so in addition to having like a straight percentage of the fee, you also have to work with inflation. And that is where like really the negotiation takes place for me. Is that if this is going to be a 3-year study or a 5-year study, I need to make sure I'm projecting costs that are going to be good all those years. Generally speaking, and this is my rule of thumb, but I advise you probably to go higher until you're comfortable. I assume it's about a 5% increase with the hospital every year. That's what I've found to be the case in my time at the cancer center. So what I like to have in this working budget is I put in all my CPT codes so I can cross-reference where I'm getting these prices from. I'm putting in my technical fees and my professional fees, all the components that make up the charge from the hospital at full there. And then I've got kind of a line that gives me an idea. I have this formula driven so that I can that 65% that you see the yellow arrow pointing to, I can update that number and that will update all my numbers, all my prices that I want to have. So I start in at, ideally, we're going to start at say 65 or 70%. And the sponsor comes back and they're back eventually. They're going to come back and they're going to say, I'll give you this much. And I have to see, okay, how does that fit in? If I lower my percentage a little bit, how does that work? That's what I found to be helpful. But I recommend augmenting the sponsor budget to give you kind of an internal document that you can look at and you can refer to as your reference, because it's going to take you a while to price out all these various pieces. And what you're going to want to do is then use that, and you're going to want to massage that until it fits for their budget. So I use an institutional charge master. There's a reliance on CPT codes for the most part, although not everything has a CPT. Sometimes you have to work with CDMs. It's dependent on the cost center. So like a lab cost can be up to twice as much depending on where it's being done at UI Health, depending on whether it's in this building or that building, whether it's with surgery or whether it's at oncology. So to find that out, you're going to ask the PI or your skilled coordinator who is going to be doing it, where it's going to be happening. And once you find out, if you don't know from there, you need to find out how it will be billed. I actually had a meeting with my staff this morning, and I'd say we spent about 40 minutes looking at colectomy charges. Just so we could price one item, the who, the where, the what was happening. It's just a lot of information. And that's why kind of getting it into that working budget so you don't have to keep working on it over and over again is helpful. So I kind of talk about different discounts that we have. Here's just examples. This is just an example. Don't take this as gospel. But I see it, say your discount is 50%. I say at year 0, because usually it takes a few months to get a study up and running, and we might be in a new fiscal year with new rates. But if we're in year 0, then you've got a 50% rate is what you'd be charged today. But if you inflate by 5% every year, by year 3, you're at almost 58%. By year 5, you're at 63%. So you have to figure out what you're comfortable with. Sometimes you can be comfortable taking an average. Okay, we're going to be open for 3 years. The average rate over 3 years is going to be 55%. So that means as long as we accrue pretty evenly among year 1, year 2, year 3, that 55% rate should do fine for us. We should be a little bit overpaid in year 1, a little bit underpaid in year 3, and we should be able to make ends meet. Honestly, for many of our studies, we're open for 3 to 5 years, and we're expecting to have 2 to 3 patients. So I don't know when those patients are going to hit. So I have to be a little bit more conservative in terms of what rate I'm going to be aiming for in my budget negotiation. But you should have the end in mind, what you're willing to settle for as you're doing this. Okay. I am really verbose today. Let's see. Other costs to consider is effort. So that's annual effort is part of your administrative fees. So at least I would recommend doing that. So we are hopefully going to be talking about administrative fees in a minute. But the cost for the PI to be the PI of the study, to be the one making the decisions and being the one who answers all the questions and who leads the effort, that is something that is kind of separate from patients coming on trial. That shouldn't be put into your per patient effort. That should be built out of your milestones, or sorry, your administrative fees. So an annual fee from your startup and from your maintenance fees, that's how you're going to be paying out that effort. There's plenty of per patient things that are happening on at various visits where it's going to be a big administrative burden on your data coordinator or on your PI or on your clinical research coordinator. And those you have to kind of get an idea of like, okay, how much time is this going to take for you to do? And then put that into those milestone payments. Other things to consider is overhead. We're 25% for industry, where I think our federal rates actually have gone up since I think, I don't know if they're like 59.99 or I don't remember what they are. But check with OSP for that, or the Office of Vice Chancellor for Research. And then let's get into our quick administrative fees. I'm not going to get too much dig into this. We have a startup fee that handles everything that it costs for our site to get up and running. Standard startup fees are a industry standard. What is not standard is how much, a site will charge or a sponsor will be willing to pay. But that is why having this written down and having a formal fee like a structured list of here are our fees and make it universal. That gives you so much more negotiation power for saying, this is just what we do, take it or leave it. As opposed to having to go into the minutia of trying to scrape as many pennies as you can. We have a startup fee, we have an annual maintenance fee. We have other standard administrative fees that include our closeout fee and our document storage fee. In addition to that, we have other administrative fees. So we have fees from our investigational pharmacy, from the clinical research center that CCDS has. From time to time, we use their services. But there are other ancillary departments and groups that do things for us. Pathology, radiology does those reads. Pathology is the one doing those, getting our slides of our tumor slices. So you need to involve the other departments, make sure you know what they're going to be charging you, not only for like each incremental thing that they're doing for you, because that's going to be budgeted as part of the procedural costs, but any kind of startup fees that they may have, any kind of maintenance fees that they may have. I know that investigational pharmacy has their own set of standard fees. So does Clinical Research Center. I think so there's, because those groups also have to review the protocol, make sure they're adhering to protocol guidelines, things like that. Okay, and then there's the IRB fees. IRB fees are set by the IRB of record. They are also subject to change. Make sure you have some sort of clause in your contract, and OSP is very good about this, making sure there's a clause in the contract that says, hey, these are IRB fees right now, but we don't set them and we are not going to inflate them. We're just going to charge you whatever the cost of those fees are. To us, we're going to charge them and reflect them back to you. Here's a link at the bottom here where our OVCR keeps the IRB fees. They're the Office of Protection of Research Service subjects. Here's a quick referencing that I'm going to just scoot on past. And now we're actually at the budget negotiation. We have 10 minutes left. I'm going to get this done in 3 minutes with your questions. Time to negotiate. This is a funny mnemonic that doesn't really make any sense, but you introduce yourself, you give an indication of expectations. You want to manage expectations on both sides. You guys are both negotiating to the same end, which is a fair market value, a fair cost budget. So what I think the biggest piece that causes kind of anxiety and strife in the negotiation is an idea of expectations. Oftentimes sponsors give me their documents and they want to start running immediately. They just start sprinting immediately. And I'm like, whoa, hold the phone. This has to go to one committee and another committee and all the way out. Like, I'm doing my background. I'm getting things set up, but like, you're not going to get a contract review for months probably, because we've got to go through our disease team. We've got to go through various other pieces. And then once we get rolling though, then I am crazy insistent and urging and getting them to move as fast as possible. And they're getting upset because they're like, wait a minute, you waited for a month and a half before, you told me, you sent me your fees, we introduced ourselves, and then like it was nothing for a month and a half. So you have to make sure that you have expectations of, okay, you know, once we have our feasibility meeting, we'll be in touch in 5 days. But before we get to that feasibility meeting, these several things have to happen, and it may be a while before we are in contact. I let them know that the contract is a separate review because that goes to OSP, and then I give them our standard fee schedule and make sure that they give it to us. So basically, you take what you have from your working budget, you transpose it onto the sponsor budget. You highlight any changes that you've made to make it easy for them to review, because it's a kindness that you want them to pay back to you. They are going to send you a budget back, and they're going to highlight the things that they've accepted, and then in a different color, highlight the things that they are going to be negotiating back and forth on. Do yourself a favor, be kind, they'll be kind, and it'll be a much happier process. You're going to keep doing this back and forth. I'd say usually about, for my team, like 3 back and forths is usually the average. Sometimes we have a sponsor who accepts our costs immediately, and that gives me hesitation. I'm like, wait a minute. Are they even looking at these costs? Can they afford these costs? And sometimes it takes like 6 or 7 back and forths, and then I'm like, wait a minute. Are these guys really good for this money? Are they going to make this impossible for us to get any kind of recoup any of our costs? If you're at an impasse, if the sponsor is saying we cannot accept any lower than this and you cannot accept any higher than this, then you need to get some sort of formal letter. Our formal letter is usually saying, this is the price that we are going to be expected to pay over the life of this study. And then you have to have someone fancy sign it. Don't sign it yourself, but have your supervisor, have someone else in charge. Usually if my team is negotiating a budget, then I sign off on their letter to let them know that, like, hey, this has been reviewed by a higher level, and that, like, we are saying, yes, this is the cost it's going to take. If that works, great. If not, you need to figure out, okay, can we just absorb that cost? Are we making enough money off of a little bit extra from our RECIST read that we can cover the blood draw? And if so, great. But if not, then you need to talk to whoever is in charge of making the decision whether the study's a go or no go. Okay.
Could I ask a question about
Please,
that?
please, absolutely, Dr. Beck.
How often do you run into these where you have to give an ultimatum?
Honestly, lately it's been happening a little bit. Oh, for the ultimatum, sorry, the ultimatum, because they often ask for some sort of letter. Ultimatum, I would say once a year out of the, like, I don't know, 50 studies that we have in startup. So it's not very often. And oftentimes it's with a sponsor that does not do this often. They're not like the bigger players. We have another question?
Thank you.
Yeah, of course.
Yeah, I didn't see a line item for patient recruitment, and I apologize if you mentioned it already. Where does that fit into the cost?
Well, yeah, that's a great question. So that I would do. So that is a question. Is it going to be? Is it something that you specifically do for all of your trials, or is this going to be something very fine-tuned that you're doing for this particular trial? Because if it's recruitment that you're doing for all of your trials, I would build that into your startup fee and probably your maintenance fee as well, is to say, okay, we are going to be spending this much on radio, or we're going to be spending this much on bus ads or something like that, to fit in there. To answer your question, we don't do much on recruitment for the clinical trials office of the cancer center. I know that is bigger for our cancer center, our other kind of units within the cancer center. They have more of recruitment, but we really rely mostly on referrals and just combing through medical records for our patient set.
Thank you.
However, I have seen sponsors will pay. So if you don't see it on a budget and that's something you want to do, that is a little money that goes a long way for them. If it means enrollment numbers and accruals, it is 100% worth it for them. I don't have any experience really in pricing that, but please feel free to put those into your budget. So sponsored programs is going to be reviewing your budget and proposal, and eventually looking over your contract. the Clinical Research Finance Office is going to be reviewing your coverage analysis. Just an idea of timeline. I'm going to get to a timeline kind of at the end of this. But coverage analysis, you route that once you route your IRB. So you route your IRB protocol. That gives you kind of clearance to route for coverage analysis. And then just know that your coverage analysis is going to be the determining factor of when of allowing your IRB to go through, because the IRB is not going to be allowed to issue you your approval until they make sure with the Clinical Research Finance Office, because there's checks and balances everywhere, that that has gone through. And then contract gets negotiated. Once the contract is negotiated, IRB is approved, your coverage analysis is approved, your budget is approved. Then there's this big concurrence review that happens where the Clinical Research Finance Office is going to look at all those documents, make sure they're all in a row before the university will sign off on the contract. Here are just some more internal approvals, and this is just this is my timeline of things. I tried to make it as if I was making breakfast. And I'm sure I had good analogies at the time, but we have 3 minutes. So we have 4 different lines here. We've got a scientific review that goes all the way through IRB approval. I have a timeline. I have a alarm clock because our timeline starts once we do our scientific review. That's when our time to activation starts. So I try to get as many things happening before as possible. And I put that as the eggs, because if you're making breakfast, eggs are really the determining factor. Everything else can stay in a warmer, but the eggs, you know, your yolk's going to set. The coverage analysis, I guess I started that first. That's the bacon. That is the most important because you might want to cook your eggs in that, I guess. But the coverage analysis, that's going to start because it's going to end up hitting it's going to affect your cost analysis. And the cost analysis is what's going to feed into your budget negotiation. Once you've got your cost analysis and your budget ready to go, that's when I route the CTA and the proposal to OSP. That usually I try to hit that before scientific review, if at all possible, to give them a chance to look at some of the terms that need to be decided at the time of IRB submission. There's pieces in there in terms of indemnification and subject injury that have to be kind of reviewed by OSP, so that information can make sure it's consistent with the consent form, which gets submitted to IRB. If that doesn't happen in line, then you may be forced to do an IRB amendment at some point to put everything in line. So involve OSP early, involve the CRFO as early as you can. So I've got that blue arrow coming from IRB submission. As soon as we're submitted to IRB, we submit to the CRFO and they review everything. And then that feeds back into the IRB review. When everything is done, then everything kind of gets sent to OSP. I put them as the coffee because it's kind of the easiest bit for us. We just let that coffee, and it's the kind of the most enjoyable part of the end, right? It's the taste that's left in your mouth. But everything kind of gets sent down to them. They go and defer to the CRFO for a final concurrence. And if you get the green light, then you execute your contract. It is a long, lengthy process, but I mean, it is what it is. It takes an entire village to get this thing set and running. So I'm sorry, I'm going to call it -3 minutes for questions. I am happy to stay on and answer any questions that anyone has.
Thank you,
You'll be
Mike.
sharing the recording? Mike, you'll be sharing the recording with all the
Yes,
folks
yes.
Yes, I believe CCS is doing that.
along with the deck. That'd be great. Thank you.
Thank you. Bye-bye.
You bet. You know, I
Thank you,
practiced it in
Mike.
my head. Yeah, I practiced it in my head, but I usually do it out loud, and everyone was sleeping. So in my head, I talk much faster, I think, is what it is. So sorry for taking so much time.
If there are any more questions, if you have any more questions, you can reach out to Mike. Thank you, Mike, for the presentation, and thank you everyone for attending today. The next best practice hour will be Tuesday, May 21st from noon to 1 on clinicaltrials.gov. And we have our next masterclass on 28th and 30th May on project management in the field. Please keep an eye out for emails regarding future sessions.